prevention and really more education in our Latino population. And for our objectives, we're going to define how common melanoma is in our Latino population. We'll then talk about several different educational programs that we've developed. First, a text-based program, then a video-based program, and lastly, discuss potential barriers to melanoma care. As a little bit of background to get us started, how common is melanoma in our Latino population and then also our minority populations? And these numbers are per 100,000, so 100,000 patients, how frequently will melanoma be diagnosed? In our non-Hispanic white patients, we're looking at about 33 per 100,000. For our American Indians, it's a little over 11 per 100,000. Our Latino Hispanic population, about 5 per 100,000. Asian Pacific Islander, about 1.3, and then for Black, about 1 per 100,000. And so for some context, compared to non-Hispanic white, melanoma is about 7 more times more common in our non-Hispanic white patients compared to our Latino patients, and about 33 times more than in our Black patients. Here's some tables. We'll first start on the left. This is, we took non-Hispanic white, we put them off to the side, looking at our minority patients, and per 100,000, you can see Latinos in dark blue. They have the second highest rates per 100,000, and the second bar over is looking at mortality, the second highest mortality per 100,000, behind our American Indians. Next, looking on the right-hand side, table 2, this is a ratio of mortality to incidence, and you can see that in our Black and Asia Pacific Islander communities, if diagnosed with melanoma, these are the groups that have some of the worst mortality rates. But again, not too far behind is our Latino patients. And when we think about the whole U.S. population, we have quite a large Latino Hispanic population in the U.S., and due to their relative higher incidence compared to other minority groups, as well as their higher mortality incidence ratios, they're the ones that have some of the highest overall mortality rates in our minority communities. I do think this table, though, helps put maybe melanoma deaths into a little bit of perspective, though. This is SEER data from 2012-2016, but if you look and pull more recent SEER data, the results are very similar. The vast majority of annual deaths due to melanoma in the United States are predominantly in our non-Hispanic white patients, but because of the relatively higher amount of Latino population we have and their higher mortality rates, they do make up the second highest cohort for a racial ethnic group, followed by our Black and then Asian Pacific Islanders. So with that little bit of background, why were we thinking education could be a beneficial strategy? Really, with how low the mortality rates are, screening all these individuals in dermatology practices is probably not going to be very either cost efficient or possible with our limited dermatology population. And we had done some free cancer screening in Phoenix, Arizona, where I'm based, and among our Hispanic Latino patients, they scored, we had a little survey they filled out, they scored the lowest on their skin cancer knowledge, but also rated interest in learning more about skin cancer the highest of any racial and ethnic group, certainly suggesting to us that there is a real interest in learning more about skin cancer. At our first kind of pilot of creating a program, this was a text-based melanoma educational program. We partnered with Dr. Sancy Leachman at OHSU, borrowing a lot of her products from the War on Melanoma, but then really adopting it to having photographs of our Hispanic Latino patients at Mayo Clinic, so taking out those non-Hispanic white images and then translating everything into Spanish as well. And for this study, we really developed a survey that were given to the participants. They had the survey before interacting with the text-based educational material, post-intervention, so right after the educational material, and then 3 months later. And the predominant thing we're scoring them on is a melanoma knowledge score, which was, again, developed by Dr. Leachman with her War on Melanoma. We, as a pilot, just recruited a small percent of our Mayo Clinic Latino patients, and then also did some advertising on Facebook and social media. A little under 400 participants. during the pilot cohort, a little over 60 years of age, and about 75% were female, and this was funded for the MRI, so appreciate their support. For the melanoma knowledge score, when you looked at baseline to right after the text-based educational material, there was about a 22% increase in their melanoma knowledge. And when you compared their melanoma knowledge before interacting with the educational material to 3 months later, they still had 11% gain compared to beforehand. We might have someone else chatting too in the background. We also looked at secondary outcomes too, so in addition to the melanoma score, we were looking at behavioral changes. Were they more likely to check their skin self-check their skin to make sure they didn't have any melanomas? What were they wearing sunscreen outside, using other sun protective behaviors, and were they helping family members check their skin? And all of those increased after the text-based melanoma education. We did notice some attenuation with time, right? So although right afterwards they had a 22% gain in their melanoma knowledge, it did drop compared at the 3-month time point. So our thought was potentially more reinforcement, either reminders and or repeat education may help further boost retention of melanoma knowledge. One of the big feedback mechanisms we received from our participants is just how lengthy the text-based melanoma education was. Again, based on our work with the War on Melanoma and Dr. Leachman, she's definitely very excited but very detailed. And the whole text-based curriculum was about 45 minutes to complete. And we're really recognizing that a lot of people prefer video-based engagement, and then also we needed to drastically cut the amount of material. We ran a second study using a whiteboard-based video education program and then compared it to our text-based program we had previously. So really the design was the same with the pre-survey, the post-survey, the 3 months later. And for the video portion, we now engaged the rest of our Hispanic, Latino, Mayo Clinic population. So just under 94,000 individuals in total, about 89,000 that participated in the video-based project. And then we compared it to study 1, which in this case is the text-based project. Study 2 will be our video one. And we talked about, we were able to cut from a 45-minute video down to a 5-minute video in English, 6-minute video in Spanish. And to help make sure that this was culturally relevant to our target population, we worked in partnership with Arizona State University. We had Latino community healthcare workers help vet and watch the video and were involved throughout the video creation process. Not surprisingly, when you look at the very first thing, trend here, completion rate. So it looks like more people were, again, right over 0.05% of statistical significance here, but more people may have been completing the material just because of the decreased length of time it took to interact with the video. When we compared the text-based to the video-based solution for knowledge gain before to after, before to 3 months, or after the initial educational intervention to 3 months later, you can see that the text to video, there is no significant difference in the knowledge. So really we were able to essentially cut the educational material 9-fold, really shorten it up, and yet we didn't have any significant drop in melanoma knowledge obtained by the participants compared to the much more lengthy 45-minute text-based sessions. And here's some screenshots from the melanoma educational video. We did highlight several different types of melanoma in the top right. Some melanomas are cutaneous sun-induced melanomas, right? And so individuals that have a higher propensity to burning, they'd be the individuals who may need to be using sunscreen, protecting themselves from the sun. But there's also other melanomas that are really not thought to be UV induced. And really, everyone's susceptible to those and where to look for those. So those are your acral mucosal melanomas. On the bottom left there, we tried to include images of some of our more early acral melanoma diagnoses. So instead of giving people photos of these giant bleeding masses on the feet, which certainly is not when you're trying to have people identify acral melanomas, for lesions that are much earlier before they're very invasive. And then on the bottom right here, just kind of going through the A, B, C, D, E's, here's it kind of captured in C for color. If you have interest in looking at these videos, here are some QR codes where you could pull up either the English or Spanish version, and maybe I'll pause for a quick moment in case you want to take a photograph of this. This was, we'll talk about in a moment, but these are the websites that the participants were able to come back to at later time points that we'll talk about in this next study. So, we saw that there is a drop-off in educational knowledge at the 3-month time point. One of our thoughts is, well, does that continue to decline? And maybe at 12 months, they're doing no better than initially when we gave them the educational intervention. So, what do things look like at 12-month follow-up? So, the same study design, really an extension of what we were talking about beforehand. This was just the video-based project, so this was the 89,000 patients enrolled into that one. And what we did in addition to a 12-month check is we allowed the option for individuals to enroll their cell phone number to every 3 months receive a text message, in which would tell them, please go check yourself for melanoma. And at the same time, there was a link where they could then link to those educational videos I gave you in the QR code, and they could rewatch the video if they were interested in doing that. And then the primary outcome was the melanoma knowledge score. If you look at the baseline score versus post-video, you can see that's the biggest bump, and we kind of presented that data already. But the durability, the second point there was no drop in the melanoma educational knowledge score between 3 months and 12 months, which was really exciting. So these individuals, yes, they had a little bit of drop compared to right after watching the video, but compared to 3 months to 12 months, they still had retained increased knowledge compared to not watching the video at all. 90% of patients, so the vast majority, ended up opting into the text-based reminders every 3 months, but we also asked them if they actually went and clicked on the link and rewatched the video. Certainly not a lot of them ended up doing that, but we were able to stratify those that did versus those that did not, and interestingly enough, their melanoma knowledge scores were no different at the 12-month time point, whether they rewatched the video or not. So even just that one video watching seemed to have some durability at 12 months. What rewatching the video did do, though, is it changed some of their other behaviors. So it did increase their confidence for checking their skin for signs of skin cancer. It also improved their confidence in encouraging family members to get skin exams. So just a graphical representation before the video education, right after the video, the highest bump in knowledge, but then that durability at between 3 and 12 months. Another thing, kind of shifting a little bit of gears away from the education that we wanted to do as well, partnering again with our Arizona State University colleagues, was a qualitative study interviewing some of our Hispanic Latino patients who've had a melanoma diagnosis, and did they have any barriers to their melanoma care. And for this kind of pilot qualitative study, we developed a semi-structured interview process virtually. This was still kind of towards the tail end of COVID, and we video recorded it. We then translated it into English, transcribed it, and then analyzed it on the back end. We wanted patients who had a relatively recent melanoma diagnosis, so they're not thinking back 10, 15 years. And so our inclusion criteria is Mayo Clinic patients that self-identified as Hispanic or Latino with a pathologic melanoma diagnosis between January of 19 and June of 23. In total, 86 patients met that inclusion criteria. We contacted them all for this hour-and-a-half-long interview process. Unfortunately, only 3 ended up participating, which is a little bit of a bummer, but we're super appreciative of the 3 that joined, and certainly some of the feedback we got from other individuals is just the length of time it would take, and also not compensating them for that time. Who did the interviews? So it was our partners at ASU, so these were all individuals who are community healthcare workers that were Hispanic Latino, and then also paired with a cultural research specialist that was bilingual as well, and so they were able to conduct the interviews in Spanish, and then we were able to translate and interpret the data on the back end. All 3 individuals were female, aged between 60 and 73, and range from some college to master's degree. And again, thanks for the MRA for this funding for this project. All participants reported really that once their melanoma was identified, they didn't really have any challenges with their initial treatment and follow-up care. They did describe challenges with that first dermatology consultation appointment. I think that's something that a lot of patients struggle with. Getting into the dermatologist, there's just limited opening openings to get in, and so that was probably one of their biggest challenges they had initially. At Mayo Clinic, all of our follow-up visits are self-scheduled, and they had mentioned that automatically scheduling follow-ups would be advantageous just to help streamline their follow-up schedule. And they discussed having patient navigators would be really nice just to help navigate the healthcare system and some of the challenges or barriers that can come up. For education, and maybe these individuals didn't participate in our other earlier educational project, they discussed that a lot of the melanoma education that they had available to them really focused on non-Hispanic white patients, including a lot of the photographs were non-Hispanic white patients, and they didn't feel it really reflected their lived experience. And language as well. It was all written in English, and they felt that it was difficult for them to really bring these pamphlets home and discuss with their family, because there wasn't an option to bring home a Spanish translated version. And from their perspective, and certainly being patients in Mayo Clinic, they felt that they might have a little higher knowledge of the healthcare system and maybe a little bit more of a privileged position, and felt that their personal experiences may not reflect the entire community. And in the future, potentially doing this in more of a community setting would lead to different results. So with that, I wanted to thank the MRA for their funding and the opportunity to present today, and also thank my other funding sources in our lab.
Questions from the audience? Oh, I see a hand. On my way. This way.
Hi, my name is Sam Guild. I am with AIM at Melanoma. We're also associated with AIM at Skin Cancer. So I am very interested in the backgrounds of your patients. We're actually in the process of putting together an educational toolkit specifically for migrant farm workers who have a lower education. They are not going to the Mayo Clinics right out there. And so you got a very positive response, I saw. So I'm wondering, who were these individuals that participated in the survey, because it would help, I think, all of us better understand what we can do and what toolkits we can put together for this population.
Yeah, so for the different educational projects, the vast majority of the people, they're patients at Mayo, and this, I'm in our Arizona site, so we do have a large Hispanic Latino population there that we serve, but this also includes individuals who had visited our Rochester campuses or Florida campuses as well. They were included as individuals we could contact. Certainly that's not necessarily the entire Hispanic Latino community. We sometimes partner in research with Mountain Park, which is one of our local community clinics in more downtown Phoenix that serves a larger Hispanic Latino population that we do. And I imagine, several things that could be helpful is, one, finding the clinics that serve these patients the most, and then seeing if you can find some advocates of the community itself to help figure out what's the best way to reach those individuals is really helpful.
Hi, I'm Amy from Iowa, and I had acral. One of the things I'm understanding is that with acral melanoma, it's sometimes mistaken on the foot because it could look like a diabetic lesion, and I'm wondering if you've added that component to some of the videos to say, like, this is a diabetic lesion, but this is acral melanoma, and there's a difference to be aware of? Or, like, your doctor might be telling you that it's diabetic, but really it's acral. How do you pinpoint?
Yeah, great question. I think there's definitely good research showing that individuals who are initially misdiagnosed their acral melanoma, either it's as a diabetic foot ulcer or maybe it's diagnosed as a wart or trauma, their outcomes are worse than those who initially received the correct diagnosis. No doubt about that. We didn't specifically tell people that they should be looking out if something looks like a diabetic foot ulcer. We did include images of multiple earlier acral melanomas, what those look like. And I think in the video we may have mentioned that some people mistake it as trauma. But I don't think we specifically said diabetic foot ulcer, but hopefully the idea is if you could at least show some people and educate them. I mean, there's a big understanding that, melanoma is sun-induced, and with that, people really never think of even looking on the bottom of their feet, so even just opening that up as a possibility and showing some early acral lesions hopefully would help alert the correct patients to go have a physical exam.